Thank you, Michelle, for that introduction, and thank you for the invitation to come and talk today. Good afternoon, everybody. I'm going to talk about VZV. So we're going to talk viruses now, change from bacteria. And my topic is VZV, as you can see here. So what I'd like to do is to just sort of impress upon you some of the clinical presentations that we see on VZV. So I just wanted to highlight a couple of cases for you just to make the point of diagnostic testing and how sort of we go about doing this testing in-house. So our first case, just to get right into the matter, is a 71-year-old male who comes in to Ohio State, the history of hypertension, hyperlipidemia, Alzheimer's, diabetes, CVA, which is your cerebral vascular accident or stroke. And he's transferred over for altered mental status and suspected preseptal cellulitis. So obviously a very severe case here. Now he gets referred to ophthalmology right off the bat because they noticed some redness around the eye and that he had some swelling in his conjunctiva and associated crusted vesicular lesions around the upper middle brow and tip of the nose. So I don't know how many of you have ever queried Hutchinson's sign, because if you do query that in Google, you're going to see some horrific images of this manifestation on the V1 trigeminal distribution. Literally half of your face has this manifestation, and then you have these blister-like lesions of the tip of the nose. This is pretty diagnostic of VZV, of herpes zoster ophthalmitis, which is why I guess clinically this case was so recognizable that he was referred immediately to ophthalmology and they had the diagnosis made. But obviously they wanted to be sure, so they had a CSF drawn, a lumbar puncture performed, and as we do for all CSF studies, they always ordered a protein and a glucose and gram stains and everything else. So there was a protein elevation to 120, glucose mild elevation to 79. And reactive lymphocytes present. So angry looking cells that were large in size were seen on gram stain as well. Now, upon history, this patient, his daughter said that he had received vaccination at age 65. He's now 71 years old. So there's a lot of good discussion about VZV vaccination for zoster as to how long that vaccination lasts, and it doesn't always last for a very long time. They have a much more improved version of the vaccine now, which is now up to 90% efficacious. So anyway, this was a case where I guess there was a good clinical acumen and then confirmed by the PCR test. Our second case here, which was not such an obvious case as the first case, makes the point here. A 43-year-old comes into ICU, has a severe headache and has fever but no neck stiffness. He states he's never had a headache this severe, and the pain was shooting sharp right-sided pain with bilateral retroorbital pressure. He did not have any rashes or photophobia at the time, and no recent travel. Now, again, with this kind of a presentation, your differential is rather broad because there is really no telltale sign of any particular entity. So it could be bacterial, it could be viral. So again, a lumbar puncture was performed, and glucose this time was normal at 59, CSF elevated to 111. And again, they were very reactive lymphocytes, and increased white blood cells were present as well. So while he was at the hospital, he develops neck stiffness and photophobia, and different PCR tests were ordered. In the VZV PCR came back positive. And a couple of days later, he develops a vesicle, herpes zoster vesicles along his T5 dermatome, right? So pretty much confirming his diagnoses. Again, with this particular case, there was no obvious signs of VZV at the time, so it was really important to devise the right test. And the differential was rather broad in the beginning. So the reason I want to just highlight this case is as we get into the diagnostics to just sort of keep in mind that VZV, just as a virus, does manifest in certain forms, and sometimes it is obvious and sometimes it is not. So with VZV, we know it's a member of the herpes virus family. It's a very large DNA virus. It's about 125 base pairs long, KB. 125 kb long, and it causes primarily chicken pox in the young folks less than 10 years of age, is time when they mostly encounter this virus if they are not vaccinated. Now, I know we do vaccinate children here in the United States, but in England, for example, they do not vaccinate routinely for chickenpox. And that's where we do see, they do see certain deaths associated with VZV. And their rationale for not vaccinating in England is the fact that they want to maintain a wild reservoir of the virus, because they feel that otherwise, as one gets older, one can get very severe VZV infections if there is no wild type virus that is still circulating. So it's kind of interesting, just the thought process of different countries adopting the vaccine or not adopting the vaccine. So with chickenpox in early age, it is a highly contagious disease, and we know it has a distribution when one gets chickenpox with this blister, itchy lesions on the chest, on the face, on the head, kind of spares the periphery a little bit here. But once infected, just like as any other herpes virus, the virus lies dormant in the body and goes dormant for decades, and then and can lead to reactivation later on in life as one gets older, or immune suppression or some trigger that might lead to reactivation. And so that is called shingles or zoster, and it affects mostly adults, and there are about 1 million cases in the US every year. It can also cause encephalitis and meningitis as well. So the human herpes virus, just a little bit more about it. It infects only humans. So this is something that is kind of interesting to note, only because it has made it a little bit difficult to study this virus in the lab, because it's just hard to replicate the growth cycle and to study latency. I mean, there's a lot of research going on as to what causes this virus to reactivate, decades later in a person. And what triggers this latent virus to actually come alive again. So this is a hot topic. And there are models that have been being studied in the lab right now. So basically, one can aerosolize this virus. It's highly infectious. One can also get it by direct contact with a vesicle. But as one aerosolizes and breathes this virus in, it replicates in the lung, goes into the tonsils, from the tonsils, which is the immunological organ. It activates T cells, and then the T cells pretty much take this antigen virus and runs with it and sort of disseminates it throughout the body system, and then develops into a rash. It goes into the skin. So there is a whole mode of transmission going on when one gets exposed to this virus. And so we talked about chickenpox, and we talked about it getting dormant in the sensory ganglions, which can be your cranial nerve, your dorsal root ganglia, even enteric ganglions get infected as well. Treatment is not always given to patients, especially if it's a child that's immune competent. But in case of severe disease and shingles, acyclovir is certainly a way of treating. There's also immunoglobulins, VZIG, that is also given if somebody is exposed to chickenpox. So again, this is a nice depiction of just seeing how the varicella infection occurs. And again, the latency is the hallmark of this disease. And complications in an immune competent individual, youngsters even, is rare. But however, should there be complications, it can lead to bacterial sepsis, pneumonia, encephalitis, hemorrhagic complications, right? So, and these complications actually tend to be more severe when one gets shingles. And shingles is something that one gets as, you see it more in the elderly population. So patients who are 60 years or older, they have a risk of 30% of developing shingles. And by age 80, 85, your probability of getting shingles goes up to 50%. So it is not fun getting old. But it's just it is just the nature of life, I guess. But also obviously failed immune responses, or somebody who has suppressed immunity, somebody who's on steroids, somebody who's on pregnancy. These are just some of the triggers that can cause a latent virus to reactivate. So and as far as zoster goes, about 15% of the patients that develop this very painful condition called the post-therapeutic neuralgia, which is a painful condition, and there's not such good treatment for it, and so on. So anyway, the complications with the zoster are also listed here, which will include your meningoencephalitis, vasculopathy, pancreatitis, hepatitis, all kinds of some of these complications you can read here. So the caseload is about 13 to 16 cases in 1,000 persons per 1,000 persons a year for your varicella, and for zoster is reduced to 3 to 4 cases per 1,000 persons. So in terms of diagnostics, as you know, is very, very important, and this disease can cause both meningitis or encephalitis, right? So when you look at meningitis, there's a broad differential. You could have bacterial meningitis, you could have viral meningitis, so it's very hard to just clinically diagnose these conditions without doing actual testing. So with viral meningitis, some of the more frequent causes are your VZV, your HSV, your enterovirus, and arboviruses. Whereas for bacterial meningitis, we also have other bacterial targets. So why is it important to diagnose these viral entities? It is important because so we can at least have a little bit more of an informed prognosis. We can reduce the use of antibiotics. The whole premise around antibiotic stewardship is there a way we can stop giving broadly antibiotics to everybody who walks in? So if one has a viral meningitis diagnosed, then obviously the patient can be discharged sooner, can be put on effective therapy, and antibiotics don't need to be prescribed, right? So just shown here is your just the number of targets that are sort of more frequent, as I mentioned. There is enterovirus, there's HSV, there's VZV, and in terms of diagnostics, we know as compared to culture, PCR is way more sensitive, is about 1,000-fold more sensitive than culture. And then when it comes down to some of the more chronic conditions listed here as well, like HIV, mumps, and EBV, we know that the incidence of mumps has gone down dramatically because of the measles, mumps, rubella vaccine. So you don't see clinical manifestation of mumps that commonly. However, for these chronic conditions, serology is the go-to assay initially rather than PCR. So in terms of encephalitis, we know that, again, there are some viruses that are very prominently displayed in encephalitis syndrome. And with these guidelines, international guidelines consortium, they list some of the common ones, again, as HSV, VZV, enterovirus, and arboviruses. You'll sort of see a common theme in the more frequently encountered viruses. And again, it's important to diagnose these encephalitis causes by, again, getting a good history on a patient, first and foremost, collecting a CSF, collecting about 20 cc's if possible, and then looking at the opening pressure, the WBC counts, the differentials, the RBC count, the protein, the glucose, the gram stain as well, and then performing these targeted assays as well, or a multiplex assay, depending on what your institution chooses to use. Now, along with these PCR assays, there's also the IgG and IgM, HSV-specific CSF, IgG, IgM, that are also very sensitive, sometimes more sensitive than the PCR that can be used. Same thing for the VZV PCR, okay? You can use the IgG, IgM as well. And then there's cryptoantigen testing also in the adult encephalitis syndrome that should be considered based on the patient history, if the patient has HIV or not, oligoclonal bands, VDRL, which is for your neurosyphilis as well. So these are just some of the broad differentials. So with that background, a little bit on the VZV, why it's important, and all of that, I think I'd like to just discuss some of the results on the varicella direct test for which we were a clinical trial site that we performed in my lab. So again, coming to the Liaison MDX instrument, I think you've heard by Michelle and Jim, the instrument, the standalone instrument that can do testing for a large number of analytes. In this case, it's VZV. So efficient system requiring a very small volume, which is 50 microliters in this case of CSF sample. And again, running anywhere between 1 to 8 samples. So again, very targeted testing, no wastage, which is something really nice for me to see because there are some assays where we do end up wasting reagents because we are not able to utilize the whole assay, but not in this test. It takes about 60 minutes to get a result for the VZV, and it's again classified as moderate complexity test. Again, the workflow, I think Jim has alluded to, and Michelle, that it's pretty straightforward. There is no mixing, there's no pouring. You basically add your PCR mix and you have your sample. And there's a sensing mechanism which will sense if, in case somebody's forgotten to add their sample, it will alert you to that. So no precise pipetting allowed. So again, it's a moderate complexity test, doing one or more, 8 at a time. And it takes about less than 1 minute to set up. So now just coming to the clinical agreement, there were 8 sites that were involved in the study. We were one of the sites for the VZV study. So there were a total of 637 clinical samples that were enrolled, meeting the inclusion criteria. So these were prospectively collected and also included some banked retrospective specimens. So these samples were obviously coming from patients that were suspected of VZV, CNS infection. Now, because we know VZV is not as common, there were also contrived specimens that needed to be included in the study, where they were spiked, CSF samples were spiked, negative samples were spiked with different concentrations of VZV, and then tested on the system. And the concentration of the spiking for contrived samples varied from 2x to 50x, the limit of detection. And I'll get into some of the data on how that limit of detection was derived and so on. But this is just a broad overview of how the study was conducted. And then the Simplexa VZV results for all of these samples, they were compared to a composite reference method, which included 2 validated real-time PCR methods, and also the PCR amplified products were then also bidirectionally sequenced. So they were sequenced as well in order to confirm the entity. And a positive was considered when you have both PCR assays that were positive and the bidirectional sequencing confirmed it, or if, and it was characterized as negative if both were negative, both PCR assays were negative as well. So just looking at the data here, now this was not an easy study in the sense, as you can see, there weren't very many positives. So, out of the 637 samples that were enrolled, there were only 12 samples that were positive by the Simplexa VZV direct assay, and also by the composite PCR and sequencing that agreed. In addition, there were 2 samples that were not detected by the composite sequencing, but one of which was actually detected by an alternate FDA cleared NAT assay at one of the collection sites. Okay, so overall positive predictive agreement was 100%, and the negative agreement was 99.7%, right? So very decent, but again, the number of positives in the entire study were a little bit lower, only because of the VZV, nature of the VZV. So in our site, we were one of the sites, as I mentioned, so we collected 206 specimens, and of course, the number of positives at that time was only 2 from our site. However, out of these 206, 181 were enrolled and were included in the FDA submission. 25 were excluded for various reasons, which were, I guess, they didn't meet the specified criteria for the study. Out of these 2 samples that were positive, well, both of those samples were positive by Simplexa VZV assay, and also composite sequencing confirmed those samples. So 100% positive predictive agreement and 100% negative predictive agreement on those 2 samples. Yay! So that was good to see. Now, as I mentioned, in my institution, we sort of have a mix of different assays. We offer singleplex assays for VZV, HSV, but then we also offer this multiplex assay, which is the OSU BioFire CSF ME panel. So it was really, so what I wanted to do was just sort of give you a little bit of an introduction to this assay and how many positives we see with this multiplex assay. So again, no surprise to all of you who are looking at this data to see first and foremost that this assay can identify 14 different targets. There are viral targets, there are bacterial targets, and then there is a fungal target, which is in Cryptococcus neoformans. And again, you can see that the viral targets are more frequently encountered as compared to the bacterial targets. You can see by the numbers of positives. And again, amongst the viral targets that you can see, we again, just as we were going through all our criteria, you see more commonly HSV, you see enterovirus, you see VZV, right, represented. Now, HHV6 is an enigma. You do see 31 samples that are positive, but honestly, just getting a positive in the CSF by the BioFire panel, I think that you probably have read literature as well. It's just hard to know the significance of that result without really doing some peripheral quantitative HHV6 determinations as well, because this could just be a carryover effect in the CSF and not necessarily depicting encephalitis. So anyway, that is our sample size of what we see at OSU with the BioFire panel. Now, in our situation, as I mentioned, we enrolled 206 samples for the Simplexa VZV study. And we had also incidentally ran the BioFire panel on 175 of these samples that were enrolled in the study, right? So so it was natural for us to see how the BioFire assay compared to the Simplexa VZV direct assay. So you can see the two samples that were positive in the Simplexa study were also positive by BioFire. Okay, so again, that was reassuring to see that the sensitivities, for both of these two samples were detected reliably by both assays. And then, obviously, since the overall positivity was low to begin with the study with prospective samples, the contrived samples were also utilized in the study to be able to determine how reliable Simplexa is. And again, the contrived samples were spiked at 2x to 50x the LOD. And there were 120 samples that were spiked with VZV and 120 that were negative. And you can see for this, pretty much all samples except for one was not detected from the positive group of samples. And the one that was not detected actually had the discordant resulted because a CT of 40, which was close to the cutoff. So again, at that low LOD, it can be a hit or miss at that point. So there was a CT of 40. But overall, positive predictive agreement is 100%, negative predictive agreement with these contrived samples was 99%. The LODs, as I keep talking about spiking the LOD, how do they determine the LOD for the Simplexa assay? So by the way, these data slides I'm showing is really all for informational purposes because, as you all know, this assay is currently is with the FDA and they're awaiting approval. But I think it made a lot of sense to just at least show some of the data that has gone into the submission for this talk today. So in terms of the limit of detection, two VZV strains were utilized, the 9939 and the LN strain. And these strains were serially diluted into a negative CSF matrix at different concentrations. And then the LOD was determined as the lowest concentration that can detect greater than 95% of the time, right? That's your typical way of doing LODs. And so again, with both of these strains, you can see with the probit concentration and doing the digital droplet PCR. So this was digital droplet PCR was utilized to determine the copies per reaction and then also the probit analysis. So you have 9 copies or 12 copies per reaction limit of detection for both of these strains. The analytical reactivity was also checked against different strains of VZV virus. As you know, VZV virus can have many different strains. There are also different genotypes and so on. In this case, the Simplexa assay, it utilized a 2 times LOD, was spiked with these different strains of VZV, and they were ran in triplicates. And again, looking at these different strains shown on the table, you can see that these were detected very nicely at the 2 times limit of detection by the Simplexa assay. And they also did, I believe about 178 additional strains in silico blast analysis to see that these other strains at the primer probe region and everything was well covered for all of these other strains as well in silico. Now, cross-reactivity is important to make sure there's not a false positive that one can get with different organisms, with bacteria, fungi, parasites. So about 159 microorganisms were spiked into negative CSF again in triplicate. And for those other ones that were not available at the time, outside of the 159, in silico analysis was done, and there was no cross-reaction observed after spiking these entities into negative CSF. And likewise, the microbial interference was also determined with these 159 microorganisms in the presence of human white blood cells, to see if, because there's pleocytosis and so on, cell infiltration that occurs in CSF as a result of infection, to see if any of this could be interfering as well. And there was, again, no interference at the 2 times LOD spiking with these different interfering substances and VZV. So there was also testing with interference substances because, as you know, body fluids and so on, we need to just make sure that there is not going to be any interfering substances. So there are 16 interfering substances that are listed here. And again, these were spiked into your 2 times LOD concentration of your VZV virus with 2 different strains of VZV virus, the 9939 and the LN strain, along with these interfering substances, and there was no interference detected with these assays. Now, one of the things that I always think about when I think of a direct VZV assay, and a question that had come up for Jim as well, is how sensitive is the direct Simplexa assay? Are you going to lose some sensitivity or not because you're not doing a formal extraction with these CSF samples? And that's something that I always think about when I'm bringing on a new assay. But I was quite interested to see here in the sensitivity comparison that was done with the Simplexa VZV assay and the other assay, which is your ASR, VZV ASR sample, where there is extraction performed ahead of the amplification, that the VZV Simplexa direct assay kit actually performed better than the extracted ASR sample. And I can't really point here. Let me see. Oh, there you go. So you can see, so again, there were these 2 different strains of VZV that were tested, the LN and the 9939 strains. And these are the copies per ml that were used for spiking. And again, you can see that looking at the Simplexa and the ASR in terms of how many samples were detected, the Simplexa assay actually was more sensitive at these different concentrations as compared to the ASR assay after extraction. So this is also just your CTs as well, cycle threshold values shown here, and the number of positives, replicate positives shown here. So this was very interesting to see. And I believe there is a poster, right, Michelle? That's tomorrow on Tuesday. That will go into more details of this analysis if anybody's interested in seeing more data on that, if you'd like to see this. So, so with that, I think I will end and see if you guys have any questions. I'll leave some time for questions if there are any. Thank you. Please feel free to come up. I don't know, how many of you do VZV testing in your labs, I guess? Do you guys test for VZV in the lab? Yes? Multiplex or singleplex? Both? Yeah. So are you going to have both assays around, or is it going to be more clinical acumen that you're looking for physicians to order one or the other? Yeah. Yeah. That's pretty much what we do too. We offer both of these at this time, and hoping that it's going to be good clinical judgment, so we don't have to use multiplex panel unless and until we absolutely have to use those. Yep. All right. You guys have 4 minutes to spare. Thank you.